That's for you.
Thank you so much, Amita. Thank you, the organizers, for inviting me for this presentation. It's indeed an honor. I also happen to be the only live speaker in this session, so you better make the best of me, right? Okay, so I've been given... Right, fine. So I'll try and leave enough time for it. I've got 20 minutes and hopefully leave a few minutes for questions at the end. So I've been given to speak on urinary incontinence and bladder pain syndrome. And I have no disclosures for this talk. Both bladder pain syndrome and overactive bladder are essentially problems which do not have an etiological diagnosis. We are making a symptom-based diagnosis of these two conditions. And we know that both of these are problems related to the afferent signaling system in the bladder. Both of them happen to be fairly common in society. So we know that in the patient with bladder pain syndrome, we believe that the frequency is primarily triggered by pain, vis-a-vis the patient with overactive bladder, where the frequency seems to be triggered primarily by a sense of urgency. Now, I must caution you with this slide because this is something that I have actually compiled from the presentations of different papers. So this is the EPIN-CONT data, a large study, 2001, which shows the prevalence of overactive bladder in the general population, about 25% or so. I've superimposed on this. This is the prevalence data for bladder pain syndrome. If you take the high sensitivity prevalence is about 6.5%. Oops, sorry, something happened. The high sensitivity prevalence is about 6.5%, the low sensitivity is about the 3 to 6%, 7% band. And then I have superimposed the USI guidelines, the Urological Society of India guidelines, prevalence for incontinence in India. Again, age-associated prevalence. And you can see here, do we have that pointer? There's no pointer? Okay. If you see the prevalence, you can see that both of these are fairly prevalent. Both overactive bladder and urgency incontinence are much more prevalent in society. And depending on which definition of bladder pain syndrome you're looking at, it's about maybe 4-5% or so in the general population. So clearly, both of these conditions could occur at the same time coincidentally in your patient. But we need some perspective on this because when you look at data in terms of exams with patients with papers which are looking at overactive bladder and bladder pain syndrome, how we define what's overactive bladder and bladder pain syndrome makes a big difference as to what data you're going to get. And let me show that to you. Let's say I decide that if a patient comes to me with any significant component of pain, I'm going to label that patient as bladder pain syndrome. In that case, what I will get is the incidence of overactive bladder in my bladder pain syndrome is going to be quite high. Because you can see the moment they have any pain, they get included in the pain syndrome group. Hence, you are going to get more of an overlap of urgency in the bladder pain syndrome, but you'll get less pain component in your overactive bladder syndrome group, right? But if on the other hand, I define any major urgency as overactive bladder, what you're going to get is the prevalence of overactive bladder in your BPS patients will come down, and the prevalence of pain in your overactive bladder patients is going to go up. Now the thing is, you may not be able to really understand unless you look carefully at the methodology of a paper where they have drawn their line. But I can show you here that depending on where that line is drawn, the prevalence of pain and urgency in these cohorts of patients will differ markedly, right? So I would suggest that whenever you look at a paper of OAB and BPS, try and understand where that line has been drawn. And that will tell you what to expect from the paper. So with this background, let's look at the prevalence of urinary incontinence in BPS. This is from 2022 Dubinskaya's paper. 144 patients with bladder pain syndrome and 57 healthy controls. This is Veterans Affairs US data. 81% reported incontinence, and this incontinence was substantial in 40%. And you can see here that's how they subcategorize the degree of incontinence. A strong desire to void was associated with urine leakage in 69%. And what they said was, from their paper, that the traditional differentiation that we have, that the fear of pain is what makes these patients go more often, might be a simplistic method of looking at this. And in fact, many of the patients with bladder pain syndrome might actually have both components of frequency and urgency. Not just a fear of pain, but it's actually the true urgency which might also be there. But as we will discuss in a later slide, the urgency may qualitatively differ in these patients. Let's look at the prevalence now of pain in overactive bladder and urgency incontinence. This is LIES data, 26 patients with BPS, 53 OAB and 30 healthy controls. 1/3 of patients with OAB reported some pain or discomfort on bladder filling. And the ICIQ urinary incontinence scores were higher in the OAB patients, as you might expect, compared to the BPS patients. Looking at this from the urodynamic perspective, Minaglia et al. Reported in 2005 on 47 women who had detrusor overactivity, and mind you, this is different from overactive bladder. 18 had detrusor overactivity incontinence, 40% of these patients had pain. They did a potassium sensitivity test. Arguably, this is not the best method to make a diagnosis, they exclude one. And they suggested on the basis of their PST that refractory patients were more like, BPS IC was more likely in the refractory OAB patient, something that many of us experience in our day-to-day practice. But then what do the guidelines state? So let's look at the guidelines examining pain in overactive bladder and urinary incontinence. The AUA 22 guidelines mentions the word pain twice. Once in relation to painful defecation, and once in a statement saying that patients void to avoid incontinence versus pain, depending on which you're looking at. The EU guideline mentions pain only in relation with mesh-associated women following incontinence surgery. So, and the 2019 guideline, Urological Society of India guideline, to which I am the lead author, does not mention the word pain at all. So the symptom of pain is a blind spot in contemporary guidelines. It just does not figure. Let's look at it the other way around. What about OAB in BPS-IC? What do the guidelines state for this? The AUA 2022 guideline, there's no recommendation with regard to the use of OAB medication. The EAU 2022 guideline, no recommendation. But is that what you in your clinical practice experience? Many of us actually use OAB medication in our patients. I'm sure if I ask you for a show of hands, how many of you have ever prescribed an OAB drug for a patient who comes with BPS? Let's have a show of hands. At least I have. That's not what the guidelines are showing. So clearly, there is something wrong in the way the guidelines have been crafted, because there is a component of urgency that patients would be having. We recognize it in our patients. We see it in the literature and yet don't find it in the guidelines. So there's a lacuna somewhere, right? So therapy for OAB is a blind spot in contemporary guidelines for BPS OAB, BPS IC. So let's get a little bit of more perspective on this. Is there a difference in the characteristics of urgency between patients who have BPS IC versus patients who have overactive bladder? Now we know one part which you must have discussed yesterday, I was not there, and we have had this discussion repeatedly, that the urgency seems to be primarily secondary to a fear of pain rather than a fear of leak in the typical patient with bladder pain syndrome. But there are other issues. So if you look at the ICSI question 1, the question 1 asks, does the woman or does the patient have a strong need to strong need to urinate with little or no warning? But this strong need to urinate with little or no warning, which is part of the ICSI symptom scores, doesn't truly capture the nature of the urgency of the BPS OAB patient. Most BPS OAB patients don't complain this way. They actually have a crescendo of pain happening over a period of time. It doesn't come on suddenly. So this question which is there in the ICSI question 1 is not really crafted correctly. It needs to be reframed to capture the urgency which patients of OAB BPS have, BPS IC have, because this question is more directed at the patient who has urgency incontinence rather than the patient who's got BPS OAB. BPS-IC, sorry, I'm confusing the words, the abbreviations. Also, if you talk to your patients, very few patients who have bladder pain syndrome will in fact use the word urgency or your local language translation of the word urgency. They may use very many other different words to describe their feeling. We might call it as urgency, but they might not actually use the word urgency or its literal translation into your respective languages to describe their symptom. So what about distinguishing symptom clusters of OAB and BPS? So this is from 2018, and the authors Ackerman et al. And BJUI International showed that the classical tools of female genitourinary pain index or ICSI OAB questionnaire, they lack adequate discriminant value to differentiate a patient of OAB from a patient of BPS. And that these sensitivity and specificity where the accuracy overall was somewhere around the 60-65% mark, which is just not adequate. So what they did was they took 48 patients who had who became their pilot group, and with this they tried to develop a nomogram, and I'll just show that to you in a moment, which they then revalidated in another 147 patients to try and see whether they could define a method from the questionnaires to identify a patient who has BPS-IC and differentiate that patient from a patient who has OAB. And this is the nomogram that they came up with. It's a little complicated, so I won't go into all the detail except to say at the first step, they looked at patients who had low bothers. If they were low bothers, they went into the control group. If they had a bother, then they examined different parts of these questionnaires in a numerical manner to develop an index. And then patients who fell in the OAB group with where the fear where it was low track symptoms dominated by urgency, they were able to differentiate those patients, which is the patients in yellow on their graph, from the patients who had the bladder BPS-IC, which fell into a demarcated area on their nomogram. So they felt that this method of assessing which they have, and this all comes from the patient-reported outcome measures. So they just use the same patient-reported outcome measures, but they use the information from the PROMs in such a manner that they developed a nomogram by which they felt that they could differentiate the patients better, and at least in their center, it worked well. But this brings me back to my perspective slide on where you're drawing your line. Now, where you draw your line between BPS and OAB makes all the difference as to how you categorize your patient. And that explains to you why what works in, say, Shivam center or Aparna center or my center might not work in your center. Because where I draw my line might be different from where he or she you draw your line. And hence you are not able to apply that data to your data set. They felt that their diagnostic accuracy was 94%, but unless you have a validation of the same thing across other population centers, different institutions, with their own cutoff lines, you will not really be able to understand whether you can use this information in your practice. So what are the urodynamic findings in patients who have BPS-IC? We know that a substantial proportion of patients do show detrusor overactivity. And there's a caveat here. You can get detrusor overactivity even in normal individuals just by the act of filling the bladder in a non-physiological manner. Patients with detrusor overactivity can complain of pain, and they might be unresponsive to therapies. And sometimes it's difficult to differentiate the detrusor overactivity of urgency incontinence from the detrusor overactivity of a BPS-IC patient. This all comes from the AEA 2022 guideline. So Shim et al. Examined a fairly large cohort of patients with BPS-IC and overactive bladder, severe overactive bladder with urodynamics. They found that detrusor overactivity incontinence prevalence was not different statistically, but if you look at the numbers, there is a clear trend that the severe OAB patients had more detrusor overactivity in them. But what they did find was that the maximum bladder capacity was lower in the patients who had BPS-IC, and an entity which they called volume discrepancy. What's volume discrepancy? They defined volume discrepancy as the difference in volume between what the patient produced on their bladder diary as their maximum bladder capacity and what they found during the test. So we know there's often a discrepancy between these two, right? Because when you're doing a urodynamics, you're artificially filling the bladder. And hence there's often a discrepancy. This discrepancy was different in these two groups. So you can see the discrepancy is more in the patient with the OAB group compared to the patient who has the BPS-IC. And they did the ROC curves for this, and they found that the area under the curve for both of these was best as a discriminant factor on the urodynamics. So now let's look at cross-efficacy between various therapies. And I've got 4 slides on this to cover orals, intravesical, and 2 forms of salvage therapy. There is not too much of data on all this, so I should warn you about that upfront. So we know that antimuscarinics and mirabegron both seem to show at least some benefit in patients with BPS-IC. Again, bringing me back to the point, there is some data to show it might help. Clinically, many of us seem to use it, but the guidelines seems to be a blind spot on the guideline, as I said. So at least in our practice, we have 2 different groups of patients. There are patients who complain of pain but don't really have a significant urgency frequency component. There I would almost never use an OAB drug. But if there is a significant frequency urgency component to their symptoms, even if the primary urgency seems to be because of a fear of pain, I have no problem whatsoever in initially at least challenging them with an OAB drug, because even if I can get down the symptoms by an additional 15% with that, I think the patient is comfortable or happy to have that incremental reduction in symptom. Intravesical medication, very little data on this. I could only find a systematic review on resinifera toxin, which is no longer actually in clinical use. This systematic review looked at the treatment of IC and detrusor overactivity, 7 trials, 355 patients, and they showed bladder pain was significantly reduced after RTX therapy in patients with either of the 2, and the average decrease was about 0.42 on the visual analog scale. The maximum systometric capacity was increased in patients with detrusor overactivity, but not in patients of IC. There was no significant improvement in frequency, nocturia, incontinence, or first involuntary detrusor contraction. But as you can see, some cross-efficacy in terms of 2 related conditions. And that brings me to the 2 important salvage therapies that we have in both the individual guidelines. So both the guideline for OAB and urgency incontinence and the guideline for BPS-IC has botulinum toxin in it. So we know that these possibly work by blocking the afferent, reduction in pain as compared to the placebos, and in small randomized trials, it's been clearly shown that 100 units of botulinum toxin is efficacious. There does not seem to be a difference in trigone including or sparing approaches. It's possible that BPS patients have less propensity to develop voiding dysfunction following botulinum toxin injection compared to patients who have overactive bladder. But here again, a small caveat. If you look at the retention...
Dear Professor, the time of the talk is going to be over.
2 minutes? 2 minutes, okay, right. I think I've got 2 minutes, right? Okay, so I'm almost done. So patients who have BPS-IC, in the OAB group, when you inject botulinum, some contemporary data does not show as high retention rates as some of the initial data seem to suggest, especially with higher dosages. So if you look at, let's say, Emerson's trial with 200 units, the retention rate is only 8%, right? What about sacral neuromodulation? Again, very small studies. The efficacy seems to be roughly equal historically with the OAB patients, but presence of BPS is considered to be a risk factor for need for explantation of the SNS. So if your patient has bladder pain syndrome and you're planning sacral neuromodulation, although it appears that the efficacy should be similar, it's worth counseling your patient that there's a slightly higher chance of needing explantation. The meta-analysis of sacral neuromodulation for BPS-IC shows a benefit in both the symptoms of pain as well as the symptoms of OAB, and this is reported in 2019 in the Blue Journal. Right, so that brings me to my conclusions. Overactive bladder and urgency incontinence are common in patients with BPS-IC. The association probably cannot be explained by a mere coincidence of these 2 conditions in the same individual. Seeking an active diagnosis of overactive bladder in your patient with BPS can help initiate therapy for the OAB at the outset, and any incremental symptom improvements might be useful to your patient. The coexistence of these 2 conditions in the same patient seems to be a blind spot for both sets of guidelines, the guidelines for OAB as well as the guidelines for BPS. And salvage therapies for these two conditions have overlap, and benefits whatever we see might be because of the overlap between these two conditions. Thank you.
Thank you.